Thank you very much. Everybody sat in the back. I hope that I would do the same thing if I were. So I hope to make this interactive. We got a small enough crowd. It's truly interactive. I want to learn as much from you as hopefully you'll learn from me. I learned a lot by preparing for this. As a surgeon, and I'm ashamed to say I have a background in health and sports science, not necessarily public health, but health and sports science. I knew very little about smoking and cancer. My job as a surgeon is to take it out. If it's bad and it's cancerous, our goal is to take it out. And what I found through this, and I'll talk a little bit about that at the end, with specifically pancreatic cancer examples, we probably will make more strides and more progress with prevention, especially smoking prevention, than we would ever make with surgery or chemotherapy or radiation, which is where all of our time is spent, especially all of my time in the cancer center, spent thinking about how to do better surgery, how to get a better mix of drugs, how to offer radiation and where it fits in and all that kind of stuff. And as you guys know, with pancreatic cancer specifically, we haven't made a lot of progress in about 50 years. So with that, we're going to get started. I appreciate you allowing me to be here. So the objectives today, we're going to talk about or identify the malignancies that are associated with smoking. This talk could be like 30 seconds. I could just say smoking causes cancer and we'd be done. Or we could talk all afternoon about this and go into the details of the mechanisms and things like that. We're going to try to go somewhere in the middle, especially with the Surgeon General report this year. As you guys probably know a lot better than I do, that was broken down by chapter and by organ system. They talked about respiratory and so on and so forth, but in chapter 6 they talk about the effects of smoking on cancer and specifically talk about specific cancers and whether there's sufficient evidence with the data that's available to say that smoking causes that particular cancer. And if my computer works really well, I think there are about 200 pages in that chapter, but if you flip to the next to the last page right before the references, it gives you a summary statement, and so it's pretty easy to follow for you back at home. We're going to discuss how smoking impedes the optimal treatment of these malignancies. Not only does it contribute to and cause cancer, but it also prevents patients from being able to get what they actually need to treat the cancers if they are treatable. They are at increased risk with surgery and increased risk with chemotherapy and chemotherapy effectiveness and increased risk with radiation. And then we're going to talk about a little bit about, maybe discuss, the smoking's impact on the future of cancer. And we'll talk a little bit about a study that was published or released on Monday from California by the PanCAN, Pancreatic Cancer Action Network, talking about the trends and new trends in pancreatic cancer and how smoking relates to that. You guys have seen this. This is 50 years ago, the first Surgeon General report that talked about the ill effects of smoking. This was a landmark report because that was during an era when tobacco was king, and a lot of tobacco money kind of ruled Washington, if you will. But that Surgeon General had the audacity to say that smoking is not good for you. It's cool, but it ain't good for you. Now, 50 years later, on the anniversary, the current Surgeon General this year released this report summarizing where we come in the last 50 years, good and bad. And so that's where I was alluding to with the chapter 6 on on smoking and cancer, and the good that we've done, and also the bad that still exists. Reasons to celebrate this report from 2014. We've seen a significant decline in the smoking rate. When that first report was released, about 43% of the population, the adult population, smoked. Now it's estimated about 20%, 21% of the adult population smokes. We have tobacco-free environments, and they talk about that. Your institution, your town may be tobacco-free. At the University of Tennessee Medical Center, we've been tobacco-free since 2011. That doesn't mean people don't smoke on our campus, but we have a sign that says tobacco-free. Whether we have the courage to call people on the carpet for smoking or not is a whole other discussion. Again, that's a whole other breakout session. Avoidance and treatment of nicotine addiction. We know what nicotine does. We know what the metabolites do. We know that it's addictive. And we've started to develop drugs and electronic cigarettes and all those things to help combat some of those things. So that's the good we've done. That's the reasons to celebrate this report. Our reasons for continued concern. Cigarette smoking still causes or contributes to nearly 5 million deaths per year. Tobacco use accounts for at least 30% of all cancer deaths. 30%. So just to put that in perspective, we're going to have about 1.6 million new cancers in 2014. Over 500,000 people, 550,000 people are going to die from cancer. This says if smoking went away, that number would go to 350,000 deaths automatically. And we haven't done any genetic research. We haven't come up with any more new drugs. We haven't done any sexier surgery. We haven't bought any robots. We haven't done anything but quit smoking. And a third of the disease goes away. And so the question is, how much money are we spending on trying to promote smoking cessation, smoking education, as opposed to all the other things that make a minuscule difference? 45 million Americans still smoke. We talked about these numbers. It used to be 43% of Americans. Now it's about 20%, more men than women. Is everybody from Sullivan County here? All around the region, Appalachia? Appalachia, you guys again know Appalachian disparities as well or better than I do. There are a lot of issues here. Smoking is one of them. In several counties, especially in central Appalachia, which is where Sullivan County is, and also Knox County, one of the poorest areas in the country, per capita income. This is marked by low educational attainment, and a lot of people smoke here. And the ways we go about smoking cessation have to be new and novel to be able to reach those folks. So again, up to a third of people smoke. 78% of these 20% smoke daily, and 50% of these people will die prematurely, not necessarily from cancer, but from all the ill effects of smoking. And then the economic impact of smoking, when we have the deficit that we have, smoking attributes to $300 billion per year in cost and nearly $180 billion in direct medical costs. So what about tobacco and cancer specifically? There's strong evidence over the years that has shown a clear cause and effect relationship between the use of tobacco and several types of cancer. And those are the ones that we can prove with research that says, yes, I have a cause and effect relationship. There's some that exist clearly that we can't prove. The cancer is affected. Obviously, the most common one is lung cancer. There's inhalational effect. There's hematogenous or blood effect from damage to the cells. And there are others as well on that list. Some reports list up to 14 cancers that have a relationship with smoking, cervical cancer, oral cancer, obviously with smokeless tobacco, oral tobacco products, pharynx or the back of the throat, obviously lung cancer, larynx, esophageal, stomach, pancreas, liver, colorectal, kidney, and bladder. I want you to pay close attention to those first three on that last line, because we'll talk a little bit about that at the end. Those are going to be the top killers in the next 10 to 15 years from a cancer standpoint. 90% of all lung cancer can be related to or shown to be caused by smoking, whether that's direct smoking or whether that's secondary or secondhand smoke. Smokers are 15 times more likely to die of lung cancer than people who have never smoked. And each year, secondhand smoke causes up to 3,000 lung cancer deaths. So you're talking about 3,000, I think it's 163,000 deaths. So that's a real number if you've never touched a cigarette, that you're dying from lung cancer. Cigars are equally as risky. They have the same carcinogens as found in cigarettes, and I don't smoke, but what I read, they're flavored cigars that make them more palatable and more sexy, especially for teenagers. And so that's kind of the new cigarette for teenagers, are these flavored cigars and things like that. And so that's we may see in the next Surgeon General report, 10 or 15 years from now, the rise in carcinogens from cigar use as opposed to cigarette use. But you can see here the same list of cancers are associated with that. Snuff, smokeless tobacco, cause oral cancer. We've known that for a long time. I think there's an ENT here talking about in one of the breakout sessions today talking about oral cancer. I will not bore you in the details with this. My wife told me not to put this in, but I think it just shows the flow. And I really want to look at this from a 20,000-foot view. But right here, we have cigarette smoking. We have the nicotine addiction. So, and the point of writing nicotine addiction here is that you have to smoke more and more and more, like all drugs, to get the same effect. We call it tachyphylaxis in medicine, but anyway, you smoke more and more and more to get the same effect. So you smoke more, and they're releasing carcinogens. It's injuring the cell in multiple different ways. It's binding directly. It's upregulating processes in the cell that are usually regulated, but those processes go haywire. So those cells are overproducing. And we call those are tumor cells. Those are cancer cells. And then you have effects, DNA effects, damage to the DNA. So the inability of the cell to repair itself. And then down here you have these tumor suppressor genes, which in most folks, they just kind of lie dormant. But when you have an injury to those cells and inflammation, those cells are then turned on. So that process that would otherwise not occur, now you've got a tumor process going, you've got direct injury to the cell from the smoke, and you've got a process, a cell that can't repair itself. So you've almost got a triple hit to the cell. And that's some of the mechanisms of how cancer is caused in the cell. You can see the loss of normal growth control. We call it apoptosis. And so there's cell production and there's cell death. There has to be cell death, otherwise you get an overproduction of cells. That is turned off and the cells just keep producing on top of each other. So that's one mechanism of cancer. I want to show you this last page of this report if I can, if my computer will allow me to do it. Just so you can look at it at your leisure, but this is the summary. That's like, it's not showing up. That's okay. All right, we'll keep going. That's okay. I'll come back to it at the end if we have time. So we talk about, again, in general, smoking and its effect on overall total body cancers. And as I'll show you hopefully in that report, there are some direct effects. Essentially what the Surgeon General says in their summary statement, based on the analysis of the studies over the last 50 years, there is sufficient evidence to say that smoking causes liver cancer, that smoking causes colorectal cancer. And then they get down to prostate cancer and they say smoking, we have no evidence to say that smoking causes prostate cancer. However, the people that smoke, they have a higher incidence of prostate cancer than the people that don't smoke. So there's an indirect relationship. They can't say it for certain, but there's truly a relationship with those two. Even breast cancer, they spend 50 pages on breast cancer, premenopausal, postmenopausal, smoking versus not smoking, smoking in pregnant women, all these kinds of things. And the conclusion is smoking contributes to the risk of breast cancer. So again, that summary slide is very, very important. It dumbs it all down into one slide from 230 pages, so I think it's important to look at. My emphasis at the University of Tennessee is pancreas and liver cancer. As a surgical oncologist, that's what I was trained to do it all. This is what I've kind of narrowed it down to over the last 7 years. Currently in our society, and I use this cancer, number one, because the trends are going to change, and that's one of your objectives. The trends are going to change over the next 15 years. Number two, this is just a specific cancer that you can look at what smoking does, how it will affect the trends, and what's going to happen if we don't do something to correct it. So currently, pancreas cancer is the fourth leading cause of cancer death in this country. Number one is lung.
You're talking
Primary adenocarcinoma. I always tell my patients, I'm talking about the Patrick Swayze cancer. Adenocarcinoma, not Steve Jobs, which he had neuroendocrine, which is a totally whole different can of worms. But we're talking Patrick Swayze, run-of-the-mill pancreatic cancer where almost everybody dies from it. Good question though. Fourth on the list. Number one is lung cancer. Number two is colorectal. 3, breast, and 4, pancreas. 45,000 new cases. 30. That says 39, 37. There should be 39,000 deaths this year. So almost everybody that gets this disease is going to die from it. 5-year survival is less than 5%. I did my residency. I started residency in 1998. I've been writing that same number for almost 20 years. It has not changed. And I've learned how to do the surgery from the best folks in the country, and so on and so forth. And we've got new drugs, and we've got new combinations of drugs, and all those kinds of things. And that number is still the exact same. This is the press release from Monday. This is from Monday from research out in California from the Pancreatic Cancer Action Network. That says for immediate release pancreatic to surpass breast and colon cancer to become the second leading cause of cancer death by 2020. This is essentially 2015. In 5 more years, this is going to become the number 2 cancer killer. Now, if you look in the Surgeon General report, it's not even in the report because it was not on anybody's radar up until about 5 or 10 years ago. Because I watched that number from residency go from 30,000 new cases a year to 35 to 40, now 45. And I've been practicing medicine for 7 years, just 7 years. And so it is on the climb for a lot of different reasons. And this is published in Cancer Research and so on and so on and so on and so on. This is the pancreas. This is that diagram I showed you earlier but this is specifically for pancreatic cancer. And so when we look at smoking, we know that it causes inflammatory cells. Those inflammatory cells can damage cells through cytokines and cause pancreatic cancer cells directly. The smoke can also cause genetic mutations, which we talked about, through different mechanisms. That can also cause cancer. Those cancer cells can cause endothelial. So think of this as a fibrosis scar. That causes scars. So that makes it difficult to get the tumor out when they operate. And these pancreatic cancer stellate cells are upregulated. These are always there, but they're turned on by smoking. They're turned on by inflammatory cells, which are turned on by smoking. So you can see in 4 or 5 different ways smoking is contributing to pancreatic cancer. So when you look at smoking and pancreatic cancer, all the research has really come in the last 10 years. 500 PubMed references talking about smoking and pancreatic cancer. It is the strongest avoidable risk factor related to this disease. Not obesity, not diabetes, not any of those things. It is smoking. 25% of all pancreatic cancer is attributed directly to smoking. 25%. So going back to that number we just looked at, we saw 45,000. You take 25% of that away, now you're down to 33,000 folks already. Your death rate's down to 30,000 instead of 40,000. Big deal. Twofold risk increase in smokers, and if you quit smoking, so if you're already smoking, you encourage your patients to quit, especially patients that have a family history of pancreatic cancer, their risk goes away after 10 years, and it decreases by 50% even after 2 years. It also, going back to that inflammation thing I showed you, causes or contributes to chronic pancreatitis. And we know chronic pancreatitis is a direct risk factor for pancreatic cancer as well. So that's another backdoor mechanism. And in 10 to 20, pancreatic cancer can occur 10 to 20 years earlier in patients who are at risk for pancreatic cancer through hereditary pancreatitis, which is rare. And I won't belabor this point, but again, different mechanisms as you can see: smoking, inflammation, fibrosis, all those mechanisms that we talked about are inhibited or upregulated, causing pancreatic cancer directly. Anybody know what this is? Anybody from Tennessee? Okay, everybody's from Tennessee. Anybody lived here 20 years? I know not you guys. All right, so good. I'm going to talk to this side of the room. What's this picture right here? Well, I didn't say that.
It's like a hurricane.
Okay, but just think about it. This is specifically related to East Tennessee. Now, I wasn't here. I've been here since 2007. But I was in Winston-Salem, so it affected me too. Anybody remember 1993? I'm just going to say 1993. What happened in 1993? The blizzard of 93. Superstorm. I mean, every time it snows here, I was like, everybody says, well, remember the blizzard of 93? I'm like, what happened in 93? And I was in college, and we got 6 inches of ice in Winston-Salem, so I didn't know anything about the snow. But Knoxville got 20 inches of snow. Mount Mitchell, North Carolina, got 50 inches of snow. I mean, it was truly the perfect storm. For you guys that saw the perfect storm, it was truly the perfect storm. This is what happened. Everything came together, and it was perfect, and it came together right over Central Appalachia, right over East Tennessee. So you had subtropical jet, you had the jet stream coming in, you had moisture, you had cold air, you had the jet stream dipping down, causing record lows, barometric lows, and you can see the center of this little dip right here is right over East Tennessee. And places that never got snow got snow. Look at this right here. This is Appalachia. If you define Appalachia, this is right down Appalachia right here. This blue is greater than 20 inches. Like I said, Mount Mitchell right here got 50. Knoxville got 20. Look at this, 300 deaths, billions of dollars in damage, record low, tornadoes, high winds. This is in March. This is spring break. March the what, 13, 14, 15, yeah. That's 1993. The same thing is happening with pancreatic cancer and smoking and so on and so forth. Pancreatic cancer, superstorm. And clearly nobody wants to be a part of this. But it is, from my standpoint, a person that treats this disease, it is so interesting to be in the midst of this. Not necessarily to be able to treat it and surgically take it out and all this kind of stuff, but to have an opportunity to do something about it. To change course, and then to see that course change, and then 25 years from now, we're talking about how we change the course of pancreatic cancer. But look at this. It's the perfect storm. We've got smoking. First of all, let's go down here and start. We've got a disease in which we have no cure for. So remember I said the big four: lung, colorectal, breast, pancreas. Let's talk about the big three. Lung, incidence rate going down. Death rate going down. Because why? Smoking is going down. Lung cancer, 90% is caused by smoking. Okay, that's pretty straightforward. Colorectal, it said from the report, caused by smoking. Colorectal is doing like this. For number one, people not smoking as much. What else is happening? What else has colorectal got? Screening. And not only is it screening, it's preventative. If you take the polyp out, the cancer risk goes away. Breast cancer, what do we have? Screening. We have mammography. And we have Angelina Jolie that makes it all that much more popular. And we have Susan Coleman that pancreatic cancer research, breast cancer research has more money than all the other cancers combined. So it's going down. It's going down. Even in my career, it has gone down sharply. And so they're going to go down on the list. They have to. But now we have a disease in which we have no screening, or no cure. We have no screening. We have no research money. None. We have alcohol that's stable or on the rise, especially in Appalachia where people are poor and stressed out and depressed and so on and so forth. We have an aging population, and I talk about Knoxville. Knoxville is on the baby boomer list. It's one of the great places to live. It's top 12 in the country. So we got all these older people coming to our area. They call them halfbackers. They go to Florida and it's too hot, they come halfway back. Aging population. Smoking still exists. We said 21% across the country, which is better than 43, but in Appalachia it's more like 30, 25 to 30.
So even though you're seeing the decline in smoking and increase in pancreatic, is it because of better, or because people are living longer, or is it better, is being found when it wasn't found before?
All of that you just said. That's why I said it's the superstorm. It's the perfect storm. Sometimes you get one thing that kind of pushes cancer out and then it comes back. But this is everything all at one time. Tennessee, 5th fattest state in the country. We've been top 3 before. You know, all these states right around here, Mississippi, Arkansas, Alabama, Tennessee, Kentucky, all in the top 5. They just shift around every year. So we got obesity, smoking, no research, diabetes, which comes from obesity, aging, alcohol, and no cure, all leading to this. It's going to push this thing up the list like a rocket. It's going from number 4 to number 2 by 2020. It won't ever be number 1, but it'll be a strong number 2. This is what's happening, and so this is just me just sitting back as I got getting ready for this, looking at and reflecting what's really happening. This is what we knew this is what I've known since 2008. Man, there's a lot of pancreatic cancer here. I came from Houston, MD Anderson, where we see people from all over the world. And I see about as much pancreatic cancer here as I saw in Houston, which is a world referral center. And I said, something's going on. And this is our number. So I went back as a part of my MBA class. This is my MBA project. One slide from my MBA project. And they said, well, what do you want to do? And I said, well, first of all, I want to figure out what's going on, and then I want to create a program that's going to take care of these patients. This is our number. 2008, this is into 2013. 350% increase in the number of patients we see with pancreatic cancer-related diagnoses. 350%. There's nothing that grows 350% in 5 years. So right now, this is where I am. Surgery is the only cure. So I do more surgery. I do as much surgery as I can, and it's not helping anybody. 15 but I'm only operating on 15% of folks, because the other 85% that come in, there's nothing that we can do. The median survival, and if I do my best surgery, if I have my best day in the operating room, and all my people come together, and we give a little bit of chemotherapy, and we make it all come together perfectly, they still only live 2 years. So that's why I'm talking about smoking. Smoking prevention. We've done all we can do on the surgery. This is a surgeon saying this. We've done all we can do on the surgery side. We've done it with a robot, we've done it with a camera, we've done it with high def, 1080p, and all that make it look really pretty, but we're not making any difference. Look at what smoking does though. What we can do with smoking. First of all, of those 15% of people come in that I operate on, that number goes down because a significant portion of them can't get the surgery because they smoke. They smoke a lot. And so look what happens when you smoke and you need to go to surgery. Smoking compromises the heart, causes problems with 77% greater risk of heart attack after surgery. Complications with anesthesia. You have all these secretions. They have a heart, the drugs don't work as effectively. They have a hard time getting off the ventilator. They require more medicine. The heart must work harder. So if you've got heart disease, you go back up here, that risk of heart attack goes way up. And then it's not even getting to the wound healing. What we did the biggest operation we do on a scale of 1 to 10 is probably a 9. And now all that stuff's got to heal up and not leak. And you've already put me behind the 8 ball because your stuff doesn't heal like it used to. Because nicotine constricts your vessels and doesn't bring the blood supply to the tissues that we just cut out, which is hard to have blood supply anyway, so you have complications. And then we fight a government that says you can't have complications or we're not going to pay for it. So then the question is, do you actually operate on those patients? Or do you punish them because they smoke and say, I'm not operating? It goes right here though, if they can quit, it goes back to normal. And even quitting 2 weeks before surgery reduces their risk of complications.
So are you saying that at this current time you are refusing surgery?
No, I'm not saying that at all. I'm asking, what do we do?
No, I know, but you said 77%, some of them can't have the surgery, but when an anesthesiologist screens them or is there a percentage of them that because of their compromised physical state that they're not
Yes,
getting?
there is a small percentage. It's small.
It's small. Okay.
Because again, we're the state hospital, and we're kind of the last stop shopping for a lot of these folks. And so you come in, I mean, you're looking at a patient and their family, and their 5 family members sitting in your office, and you're saying, how much do you smoke a pack a day? How long you smoked? Since I was 12. And you got pancreatic cancer, but can it be removed, Doc? Yes. Are you going to do it? Well, I may kill you with the operation because you smoke. So sometimes we do refuse. It's the minority of cases, though, I will tell you. I usually sit and counsel them and say, hey, you are at high risk of being on the ventilator, not being able to wake up after surgery. You may be in the hospital a prolonged period of time. We actually have a screening sheet and some things, some hoops they have to jump through. If they tell me they're short of breath at rest, or they're wearing 2 liters of oxygen at home, then we go to plan B.
How many of those are quit smoking after they?
Oh, there's someone smoking in the hospital. You know, on tobacco-free campus, mind you.
What?
Yes, absolutely. Does anybody else experienced that in there?
How do they do that?
They go downstairs and
They
they
go
find a
downstairs and
corner.
go outside. Okay.
Oh.
And they pour their IV downstairs.
You mean, don't go on the campus.
On the campus, not in the room. You're right.
Same.
They just go right downstairs.
I was in a room with a friend of mine that had surgery, and he was smoking an electronic cigarette in the room.
Yeah.
I see you.
Yeah, it is not uncommon. We have people that smoke and have trays, which is another story. I don't want to get up on the one right now. Don't even get me started on smoking in the hospital. So, again, what else does it do? How about if going back to your point, we say, I'm not going to do surgery now. Now we got to go to the next best. We're going to do chemo and radiation. Look at this. They got this dry mouth, lung damage, fatigue, soft tissue damage. All of that stuff is exacerbated. You get this one from radiation therapy anyway. And then when you smoke, all this stuff is exacerbated.
Like that man we just heard.
Absolutely. Chemotherapy, the drug levels, you give drugs by meters, per meter square, whatever size you are. That dose goes out the window sometimes depending upon how much you smoke. Erlotinib is specifically a pancreatic drug, that's why I put it in here. Decrease drug levels, so you need more of the drug to do the same. Increase cachexia. Cancer patients can't tolerate any more cachexia than they already have. Fatigue, infection. You have no white blood cells already from the chemo, and now you're putting yourself at greater risk for infection by smoking, and obviously the heart and lung problem we just talked about. So what are our current strategies? As I said this, and I won't again go through all this, but this is my strategy. I've looked at this all different kinds of ways, and so we put the patients in this category right here that are resectable, which means we can take it out small. That's 10-15%. Borderline means that not right now, but if you get a little bit of chemo, then maybe. And then the unresectable is most, it's about 80%. We've done different things with surgery, we've improved imaging. Long story short, you put a big X through this slide and said it doesn't work. It doesn't work well. My buddy from Houston, who's still at Edge, Matt Katz, came up with this differentiation here. And he spent his whole career so far on that. But still doesn't save any more lives. So what do we do in the future? What we're doing, and what I'm doing through this MBA program this year, is we're building a liver and pancreas program to serve the patients of Central Appalachia for East Tennessee. Now, obviously out of UT, but it's for everybody. It's going to be customer focused. It's going to concentrate on the needs of the patient. It's going to be navigator driven, so you'll call one number and everything will happen through that number. We actually already have that in some other areas. And it's going to be comprehensive. And I wrote that word comprehensive intentionally, not to say we're going to offer good chemo and good radiation and good interventional radiology. We already have all those things. We have great people from Vanderbilt and Duke and everywhere else. But this is what we want to do. As of this talk, I just learned this as I was doing this. This has got to be at the forefront, not at the end. This was an afterthought for me 4 months ago. I will be honest. Smoking and alcohol cessation, this has got to be at the forefront based on what we just spent 30 minutes talking about. Diet and exercise has also got to be in there, clearly. And this, as we talked about with the perfect storm, if you can do both of these, and I mean, you're talking people ate right, ate healthier foods, quit smoking, quit drinking alcohol, about 2/3 of cancer would go away. Not in our lifetime, obviously, but for our kids and grandkids and all that kind of stuff, it would go away. What are the barriers? Living here in East Tennessee, what are the barriers? Poverty, clearly. Educational attainment, getting people to understand the risk factors, speaking the language that they can understand. Family members that smoke. I mean, it's hard to tell your loved one that's sitting there getting ready to get a cancer operation to quit smoking when you got to go out from the wait. You leave the waiting or leave the room to go to downstairs to smoke while you're waiting on them. Lack of transportation to smoking cessation programs. We run these programs all week, Saturday, all that kind of stuff. But people can't get there. Ethro doesn't wait for you to use go to the smoking cessation program. They bring you to your appointment. You meet them back. If you miss the bus, you miss the bus. Limited time for healthcare providers to actually provide education. You know, for people on the front line, you got 15 minutes, man. You try to manage their hypertensive meds and diabetes and get their A1C. Nobody's talking about smoking cessation. And we have a shortage of providers in this region and minimal exposure to tobacco-free environments. A lot of the people that actually need the help don't live in tobacco-free communities or go to tobacco-free restaurants and all this other kind of stuff. So what can we do? And I wrote ounce of prevention, a pound of cure. I used to be on the cure side. Cure. But we need to be on the prevention side. Abstinence in school. We got to be talking to these guys over here about the flavor of cigars and not smoking and so on. It may be cool. I don't even know if it's still cool anymore in school. But it's not cool, especially when you start growing these cancers. Tobacco-free environment, I have to be willing to step outside and say, sir, you know, this is a tobacco-free campus when I see people smoking in the corner. And now, I'll be honest, I just walked away because I don't want to get into it with the patients. And our CEO doesn't want to get into it either because it might drive people away. He said, this is a tobacco-free campus, but don't, you know, lord it over people. Model being tobacco-free. As healthcare providers, we can't be smoking. That's the bottom line. Contract with patients prior to intervention. Like you said, your point, I have to refuse to operate on patients if they're smoking. I have to be that courageous to say, I'm willing to take a dip in revenue, dip in patient visits if I don't operate on them. Make it convenient for patients. Weekends, during the day instead of in the evenings or on weekends. Webcasts, mobile units like we have mobile mammography. And then nicotine replacement, which you guys know a lot more about. We talked about the big four, what they are right now. This is where they're going to be in 2030. And these are the take-home points that I have. Smoking initiates cancer. It is responsible for 30% of cancer deaths. But we can avoid this by controlling the risk factors that we have control over. And that's going to have the greatest impact on the future trends in all of these diseases. Lung is still going to be number one. Still, if we quit smoking that, we said 90% is caused by smoking. So if we quit smoking, that disease goes away. In another generation, we wouldn't even be talking about it. Pancreatic cancer, we said that 25% of it would go away. Liver cancer, in that report, directly caused by smoking, that would go away. Most of the liver cancer is secondary to colon cancer, which is metastatic. So if you get rid of the colon cancer, the metastasis go away. Must be radical in order to make a difference. We got to be outside the box. We can't keep doing things that have already been done unsuccessfully. We got to be willing to speak to that person in the corner that's smoking in a tobacco-free environment. And this is kind of some of the same stuff we talked about. And I think we got 1 or 2 minutes for questions, comments. Yes, ma'am.
I have 2 questions. First of all, cigars is big with 20-year-old boys. Mm-hmm. And they say I don't inhale, so it's not bad for me. So I'd just like for your comment on that. And also, back on the pancreatic, I collect cancer data, so I'm interested to hear if it's not because of tobacco, if tobacco is not in that person's back history, what are you saying the trend is for a lot of these cases of pancreatic? Age? You're saying the age? Age
is probably going to be the greatest risk factor for all cancer. So let me answer your first question. Go back to I don't inhale. And I've never smoked, so I don't even know how possible that is. Who said that? President
Bill Clinton.
Clinton, yeah. Sorry. I don't even know if that's possible or not. For somebody, please somebody, if you smoked ever before, speak up and say. But you still have the nicotine, the metabolites in your oral cavity. So even though it's not a direct inhalational effect to the lungs, it still gets into the bloodstream. Things are absorbed through the buccal mucosa, the mouth mucosa, all the time. All the time. We give medicines in the mouth, in the gums. So oral cancer, you're still at risk for. So I would say because you don't inhale, I just wouldn't use that as an excuse. And the second thing is if you don't smoke, age becomes the number one. Genetics, if you have a family history, that becomes your number two, but that's only 5% of cancers. So age is the strongest risk factor, but you decrease your risk significantly with healthy eating, exercise, and decreased smoking. It goes down 2/3, period.
And what's the difference between cigarettes and cigars? What is the difference?
I think it's the concentration of the nicotine and some of the other metabolites in there.
There's more in which one?
Cigarettes is what I understand. More in cigarettes.
Thank you.
And as far as in the mucosa, aren't things absorbed more quickly?
Absolutely. I mean, let's think about it. You brush your teeth, your mouth bleeds. I mean, there's so many blood vessels there. We give people, for people that have been nauseated, Zofran.
Right.
We put it under your tongue. It dissolves in just a few seconds.
It's like we showed earlier, it showed like you get a quick fix with the cigarettes, but a quick drop versus with the mouth, like a snuff.
Yeah.
It's more of
It's a depot.
yeah.
It's like the hormone contraceptive progesterone depot that they inject. It's just a long, slow dose as opposed to, like you said, that peak and valley. Oh, the questions somebody else have? Thank you very much. Thank you. 2 minutes? Okay.
But just a
Comment,
comment on
yes,
the question, that the process, the inflammatory cell process, that something I remember a long time ago from a professor in college saying that every cell is a potential cancer cell. And so the correlation of how these other cancers have been associated to smoking, I wasn't quite following. So, lung cancer, like you say, is obvious, but how the colorectal, the breast cancer, pancreatic cancer, that's huge.
Yeah.
And that is a very good talking point with people in a preventative way.
Yeah, because it's the unseen. I mean, people, you can see the inhalation and the smoke you blow out, and everybody gets lung cancer. But nobody, again, going back to that oral mucosa and all the blood, they don't get the bloodstream effects. Those metabolites of nicotine are absorbed directly into the blood. That's the whole addictive process. If it wasn't being absorbed in the bloodstream, then there'd be no addiction. Because otherwise, how do you get to the brain?
Right.
There's no inhalation to the brain.
Yes.
So all the addictive stuff, that's all absorbed. And this cell damage, like I said, it's causing DNA damage or the inability of DNA to repair. Just the superficial surface cells. Just think about it in the stomach. You smoke, whether it's oral tobacco or using a true cigarette, you're damaging the lining of your stomach, the mucosa. Now I tell folks it's like a carpet in your house. You've got a carpet pad, and a subfloor. Now all of a sudden you either got a really thin carpet or you got a hole in the carpet. So everything you spill goes directly to your carpet pad and it damages your whole house. It goes to your next room, it goes to the room down below on the next floor. But if you can keep that carpet intact, man, you can stop a lot of damage. But now you're exposed to acid and all the other things that cause cancer because you smoke. It's not necessarily the smoking causing the cancer, but it's the smoking putting the hole in the carpet and letting everything else cause a problem. So it's direct effects and it's the indirect effects that people don't see.
And the indirect effects are why those cancers are going to rise in the future.
Absolutely. And you can see it's hitting from 3 or 4 different ways.
Yes.
Direct, DNA, it's upregulation. Cancer cells are already there and all they need is a little boost, a little kick in the pants.
Yeah.
And cigarettes come along and do that.
Wow. That's powerful knowledge.
Yeah. Now the common product we are seeing is e-cigarette. So what have you been seeing in practice concerning the use of e-cigarette?
That I don't know because again, that's a great question. So the question is, the percentage of e-cigarette use and what effects they're going to have. I don't know the answer to that because a lot of what I've learned from doing this talk and preparing for this talk. I am kind of at the top of the food chain. Once it gets to me, there's nobody after me for the cancer patient. And so the PC, that would probably be a better question for any, if there are any primary care providers in here, please speak up. But I don't know the answer to that. I don't know what the trend is gonna be in the future and what percentage of my patients are using these cigarettes.
And when you use the word smoking in here, it's directly related to cigarettes, not cigars, the research and stuff like that, I'm asking.
Used to be, typically, I mean, I think the recent research, when you say smoking, they're talking cigarettes and cigars. And I try to be careful when I say, like right there, when I said tobacco-free, because then you include the oral tobaccos and the smokeless tobaccos and the cigars and the cigarettes and so on and so forth. Because, when we went tobacco-free campus, like, why are we saying, because I was on that committee, and I said, well, why are we saying tobacco-free? Why don't we just say smoke-free? Because you eliminate a whole lot of products if you just say smoke-free. But I think the recent literature is including the cigarettes. The old literature, I think, is probably just cigarettes.
If you split out the incidence of pancreatic cancer, do you see it in a certain age group with more intensity than you do another?
Great question. No, I think it's still a disease of age. I think all the research that I read, the median age for pancreatic cancer is about 59 to 60 years old. I think our median age at UT is probably about 59 and a half. I'm able to predict how people do, but almost solely based on age. I am seeing younger and younger patients with pancreatic cancers, but a lot of those are not the Patrick Swayze's cancers. They're the more exotic pancreatic cancers, the onesies and twosies, neuroendocrine tumors and things like that. I've got three 30-something-year-old guys right now with pancreatic cancer, but it's not adenocarcinoma, it's neuroendocrine, which is a totally different, like Steve Jobs, who lived in 9 years, once from the diagnosis in 2003. But it's still a disease of age, is what we're seeing. But because of that long-term abuse, they're not candidates to get what they could get to help them, again, get those extra 2 years. Yes. Other questions, comments?
Thank you. That
Thank
was
you.
excellent. Everyone should